The subject of my talk is heart failure in Africa, new evidence, knowledge, and gaps. The summary of my presentation is data on epidemiology, the characteristics of heart failure in Africa, how do we treat, and some take-home messages. This is a paper that I would like to share with you. This has been published 3 years ago, and it's a paper on population-based studies on the prevalence of heart failure. And as you can see, there is not a single study done in Africa. So all the data that we have and all the data that I'm going to talk about is mainly data from hospital-based, so from not community, not population-based, which is something different. The first registry that I would like to share with you is this report heart failure. This is a huge study that involved 358 sites from 44 countries and involving more than 18,000 patients around the world. The total number of black patients included is less than 5% of the total sample, and almost all were Afro-Americans. You can see here that South Africa, but mainly the private sector of South Africa, has been involved in this registry. So Africa has been, sub-Saharan Africa has been completely ignored in this study. But fortunately, a much recent study, the GCHF, that has been published earlier this year, involved 10 African countries, less countries from the Maghreb, but more countries from sub-Saharan Africa. And probably these results are more interesting for the people in sub-Saharan Africa. And what do we see? In terms of treatment of heart failure with reduced ejection fraction, you see that in the left column, so you have from low income, lower and middle income, upper middle income, and high income countries. The low income and lower and middle income countries, they there is no pointer. They use less beta blockers, not badly in terms of inhibitors of the renal angiotensin system, much less. Oui?
I think if you point to the screen, at least that's what I was yesterday.
Oh, it's here?
Yeah, but if you point to the screen, look up, show here.
No. No, that doesn't matter. And I've just signed the use of beta blockers, RACE inhibitors, and MRA, and you can see that they are much less used in low-income and low and middle-income countries compared with the other parts of the world. Not a single country has used an implantable cardioverter defibrillator. This has been already showed in a paper with a meta-analysis of different prevalence studies by a group of several friends, and tobacco is included in this one. And it shows that maybe 50% of the patients with heart failure and reduced ejection fraction use aldosterone antagonists, and only 1/3 of them use beta blockers. So we can really improve this situation. And this is, let me say, this is not primary health care. This is university institutions that participated in the study. So we can really do much better than what we are doing nowadays. Now, looking for the proportion of deaths occurring within 30 days of the first hospitalization, we can also see that compared with high-income countries, both related first hospitalization, heart failure related, or non-heart failure related, the lower the income of the country, the higher is the mortality. And it's really a huge difference. As you can see on the right, the relative risk of death is 5 times bigger in the low-income countries compared with high-income countries. And again, looking for, there is a paradox. Patients in the higher income countries, they are more hospitalized during the sequence of the heart failure, and they die much less. So it looks like we in sub-Saharan Africa, we do not keep our patients in the hospital. So the patient, it's difficult for a patient to go to a hospital, and then he dies much more than in the high-income countries. The lower hospitalization rate is related to the higher mortality in this study, as you can see. Looking for the etiology, it is more or less still the same. So we have less ischemic heart disease, this yellow bar, as you can see, compared with the other ones. Although it is bigger, it is becoming bigger and more important in the last years in some of sub-Saharan African countries. Hypertension is still the most prevalent etiology for heart failure and dilated cardiomyopathy. We still have a lot of rheumatic heart disease and compared with the other parts of the world. Comparing now the situation of heart failure in sub-Saharan Africa and in other regions of the world, I would like to show you this slide that shows that, for example, the mean age group is 10 years lower than in the high developed countries. We have, I don't know why, much less males than in other parts of the world, 52% compared with 70% in other parts, in 78 even in Asia Pacific. We have much less diabetes, a half of the other parts of the world. Ischemic etiology, as I said before, it's growing, but it's still very low, and we have a lot of mortality, which is much bigger than any other part of the world. What is our capacity to diagnose heart failure in the primary health care? This is a study that has been published a few years ago, analyzing the situation in 2 countries, in Kenya and Uganda. A large number of health facilities, 197 health facilities in Uganda, 143 in Kenya, looking for the availability of cardiac diagnostic technologies and selected medication for heart failure, beta blockers, ACE inhibitors, and furosemide. And what we see that around 50% of the primary health care centers in Kenya have radiography. Ultrasonography, it's much worse. 38% in Kenya, 46% in Uganda, and even electrocardiography is only available in 28% of the primary health care centers in Uganda. Looking for the medication, all the 3 medications, less than 50% of the primary health care centers in Kenya had the 3 medications needed, and we are not talking about SGLT2, we are just talking about the 3 old pillars for medication. So, I would say that, and going back to sacubitril valsartan, it is not available in the vast majority of the African countries, not even registered in those countries. SGLT2 are available in some, but they are extremely expensive and the people cannot afford to pay for them. One thing that we have to have in mind is that all this data is data that comes from research units in the university hospitals. So we are not talking about a patient who lives maybe 100 kilometers away from the capital, where there is not an ECG, there is not an echo. Sometimes there is a primary health care physician that is not able to diagnose heart failure. The chances that this patient has to be diagnosed and sent to a center, it's extremely low. Most of our patients, I would say that more than 80% of the population do not have access to an ECG or an echocardiogram, and they die before they are diagnosed to have heart failure. That's my guess. I can discuss this. We do not know how people are diagnosed and treated at the primary health care level. But we can do better, using all the drugs that are cheap and available and using them better, bringing them quickly to the maximum tolerated doses, and fight for the introduction in our countries of the medication that has proved to be beneficial to our patients. Simple guidelines for diagnosis and treatment of heart failure. Drugs and simple echo machines are needed to be used by primary health care doctors. Task shifting with the use of nurses and other personnel to improve heart failure diagnosis, treatment, and control, and increase the use of beta blockers and use of full recommended doses of the drugs. And these are my questions. Merci